Good morning, everyone. Welcome to Provincial Stroke Rounds. My name is Sue Verrilli, and I'm the Regional Education Coordinator with the Northeastern Ontario Stroke Network, based out of Health Sciences North in Sudbury. Today's presentation is titled Evolution of Diagnostic Criteria for Cerebral Amyloid Angiopathy, presented by Dr. Ravinder-Jeet Singh, our stroke neurologist at Health Sciences North, and the medical director of our Regional Stroke Network. Just so you know, a few housekeeping items. Handouts will be available in the follow-up email to be sent out after rounds this morning. And this webcast will also be archived and will be accessed through the link that will be provided in the follow-up email that you will receive. At this point, please just check that you're muted. All microphones should remain on mute during the presentation. A reminder that the views expressed today are those of the presenter and not the platform that we are using. There will be an interactive component held during the last 10 to 15 minutes. We'll have a question and answer period. Please type your questions into the chat section and I will read them out to Dr. Singh. As well, a reminder on the screen to please complete the evaluation. To do this evaluation, you can complete it online by clicking on the link or using the QR code that's on the screen. Or you can have print off a paper copy and send it in to us. You can email or scan the paper copy to the email listed at the bottom of the page. As well, certificates of attendance are available in the room, so please fill in your name and keep them for future reference. Go to the next slide, please. Just to let you know that our Provincial Stroke Rounds Committee has mitigated bias for this presentation. So I'll take a moment now to introduce our speaker. Dr. Singh is currently an assistant professor at the Northern Ontario School of Medicine and a stroke neurologist at Health Sciences North in Sudbury. He completed his medical school from JJM Medical College in India and neurology training from the National Institute of Mental Health and Neurosciences, also in India. He did a one-year stroke fellowship at the National Institute before moving to Calgary. He completed his 2 years vascular neurology fellowship at the University of Calgary. He has a strong interest in studying the role of brain eloquence in stroke prognosis. He is also passionate about studying long-term outcomes after stroke, cerebral collateral imaging, and symptom imaging correlation in cerebral venous sinus thrombosis. Welcome, Dr. Singh.
Thank you. Good morning, everyone, and thank you for joining. Thank you, Sue, for the kind introduction. So today I'll be talking about evolution of diagnostic criteria for cerebral amyloid angiopathy. Now, the topic might seem quite of limited scope, as also the title, but it's my intention that by end of this talk, I'll try to convince you that the amyloid angiopathy has a much wider appeal as an entity. And it has moved from the realm of pathology, where it was more of a pathological curiosity, starting with Alzheimer's, when the Alzheimer's disease was initially diagnosed in these patients, to now a validated clinical pathological entity. And again, initially, it kind of entrusts physicians in stroke. But subsequently, with expanding spectrum, it is finding a place in different fields. And just to reiterate, there are no conflicts of interest related to this presentation. And so, looking at the big picture, as I alluded, it was initially more of a pathological curiosity. And then subsequently, in the later part of the 20th century, the association was found with intracerebral hemorrhage, especially in older patients who were normotensive, because in the past, hypertension was thought to be the key mediator leading to intracerebral hemorrhages. So this was kind of a breakthrough in that thinking, that there was a cohort who were normotensive and who were elderly patients, and they were experiencing intracerebral hemorrhages, and the underlying etiology was not hypertension. And this subsequently led to more clinical pathological association, initially in the form of mainly autopsies, which clearly showed that the amyloid angiopathy did underlie a lot of the intracerebral hemorrhages in this cohort. And also a specific phenotype was recognized where the lobar presentation was the defining feature in this entity, unlike the hypertensive hemorrhages, which were deeper in location. And so that was the initial movement from just basically more of a lab curiosity to a clinical association. But then the phenotypic spectrum started to expand, and it was noticed that this condition was widespread among patients who had cognitive impairment. And that led to an association with the Alzheimer's disease and also many other conditions associated with cognitive impairment. In particular, now there's a recognition that CA itself, without producing any hemorrhage or causing Alzheimer's pathology, can itself lead to cognitive impairment. And now we are recognizing increasing number of these phenotypes, which I will discuss. And this has clearly shifted the focus to now imaging. And also with the widespread use of imaging, we are finding more and more cases of CA being diagnosed. And in particular, the geriatrician and the cognitive neurologist might find it very interesting too, because the older population who is not having any dementia or cognitive impairment also has significant prevalence of amyloid angiopathy and are at risk of having intracerebral hemorrhage. And if you look at some of the studies which I've shown here, the prevalence varies anywhere between 20 to 40% in patients who don't have cognitive impairment to up to 60% of patients have cognitive impairment. If you look only at the Alzheimer's disease, the prevalence could be as high as 90%. And even if you look only at the severe disease, because it's an age-related phenomenon, and there was a question whether this is just an epiphenomenon rather than a true entity itself. But if you really look at the severe disease where there's associated changes in the vessels, it is also seen in a large proportion of patients. So both the deposition of protein itself as well as the associated changes in the vessels are quite prevalent in older population. And this is one of the study which clearly reported that there is exponential increase as we move with each decade after 65. And looking at from the Canadian perspective, the life expectancy has already crossed 80 years with some variation between men and women. So we are probably looking at this portion where we are estimating somewhere between 10 and 20% of the population will have this condition. And moreover, this is becoming a bigger challenge because the hypertension is now being better controlled. So the contribution of the hypertensive hemorrhage to the overall ICH is reducing, and combined with aging population, the overall prevalence of the CA-associated hemorrhages is also increasing. And finally, AFib has also created a lot more issues than the initial presentation of intracerebral hemorrhage also itself, because patients who have underlying amyloid angiopathy associated ICH have much higher risk of recurrence when they are on antithrombotics. And given that we are now looking for AFibs in specific populations, especially ischemic stroke, and also in general population, given we have a lot of now wearable technology, which is leading to this recognition of many more AFibs. The question which is often posed to the neurologist is that, is it safe to put these patients on antithrombotics, especially anticoagulants, for primary prevention and also for secondary prevention? In particular, if they had any previous history of ICH, it becomes a very difficult decision. And also my other colleagues, especially headache specialists as well as epileptologists, might find it interesting because the association with headache and seizure is much higher than ICH in general. compared to all strokes in general as well, because of the sheer location, which predicts very close proximity to the cortex, leading to a lot of cortical symptoms, and also a lot of meningeal involvement leading to headaches. So these patients might initially present with headaches or seizure, and subsequently are diagnosed with amyloid angiopathy. And moreover, now we are recognizing that there are patients who are being diagnosed as in pre-symptomatic stages, where because of the headache or seizure, they had imaging. And because nowadays, most of the MR protocols, they include blood-sensitive imaging, a lot of patients are being diagnosed in the setting of headache or seizure. And finally, there are meningeal phenotypes which are being diagnosed where the headache and seizure could be a presentation. So, so I think that that would kind of kindle some interest as to that this has much wider appeal than we initially thought was limited to pathologists or the stroke neurologist. And what is most recent understanding is about these transient symptoms, although this has been recognized since the 90s, but it was only in the last 10 to 15 years that people have recognized transient symptoms being a presentation of amyloid angiopathy. Now, this would be very, very relevant to physicians who are practicing in the emergency department or in the community, because the transient symptoms are so common, and if they are neurological, they are invariably called as TIA, although a lot of these transient neurological symptoms may not be a TIA, up to 30 to 40%, depending upon the setting. And what is even more challenging is that a lot of these patients with transient neurological symptoms are put on antithrombotics, thinking that if the symptom resolved, there's unlikely that there's underlying hemorrhage or a condition causing hemorrhage. So these patients are put on antithrombotics, and this is the usual result. Not in every case, but at least many of us might have experienced this situation where presumed TIA was started on antithrombotics, and they ended up having bleeding. And many of us might have also been into this situation where, again, patient presented with not one transient symptom, but recurrent transient symptoms. And this is one of the patients I was involved in the care with, who presented with recurrent left spreading sensory symptoms mimicking a TIA. And again, learning from our mistakes and learning from the literature, I found myself, smart enough that I said, well, I won't start this patient on any antithrombotic, but let's get an imaging done. And this was a CT which showed a tiny little hemorrhage. And as a stroke neurologist, we always find it very pleasing when we are able to recognize this, especially if the radiologist misses it. Of course, in this patient, it was picked up by the radiologist as well. And so looking at this hemorrhage, it did answer some of the questions, but not all, because a lot of the symptoms were coming from the parietal area. So we thought we will do additional imaging, and we did a GRE sequence, which is a specific sequence to detect blood products in the brain. And to no surprise, you can clearly see that there is a signal in the same location with the blooming artifact, where the signal looks much larger than the original size. And this is very typical of a hemorrhage. And we then kept looking, and we found another hemorrhage more posteriorly, and a few other hemorrhages. So it was quite clear that we are likely dealing here with amyloid angiopathy. Now, interestingly, this patient has atrial fibrillation, which complicates all the management of this patient. And we all recognize this, the literature, that the transient focal symptoms, they occur in amyloid angiopathy. And what's even more intriguing is that in a lot of these patients, it does predict a future lobar ICH. So if you see a patient who had a transient symptom and has underlying amyloid angiopathy, they have a high risk of future lobar hemorrhages, especially early on. And finally, this is another patient who had a non-specific presentation, actually more of a delirium kind of presentation in the setting of background cognitive impairment. And this was the initial diffusion, and done, which showed a punctate diffusion lesion in the left parietal area. Now, for the family doctor, it did answer many questions that yes, there is some ischemic pathology going on, but the initial imaging did not include any GRE sequence. So, and I was quite intrigued by this, thinking that this will not explain either the previous cognitive impairment nor the delirium. Therefore, we thought we'll do additional imaging, especially to look for additional marker. And you can see on the GRE sequence, you see these multiple rounded lesions, which are hypo-intense, distributed throughout the cortex and subcortical white matter. And these are nothing but microbleeds or microhemorrhages, and which is clearly a signature pattern seen in patient with amyloid angiopathy. And also we looked at the subpial area, and you can see there's clearly these linear areas of or serpiginous areas of hypo-intensity along the cortex, and it's usually subpial in location, just below the pia mater, and it is called superficial siderosis. And so again, this is a very clear marker for the amyloid angiopathy. And now we do recognize that these punctate infarcts, which are cortical juxtacortical, are also commonly seen in patients with amyloid angiopathy. So this patient actually had a combination of hemorrhagic as well as the ischemic spectrum of the amyloid angiopathy. And so this leads to the question, why do we worry about the criteria? I think the, again, during the next few slides, I will demonstrate why the criteria is important. And one of the reasons why the criteria is important is more and more literature describing these different phenotypic spectrum. And now we need to put things together as to, well, these are all the biomarkers, but is there any way of putting the things together to really understand what's going on and what's the risk here? And so this was some of the initial work, and which was subsequently expanded. And recently there was a meta-analysis which was done, which showed that these superficial areas of previous hemorrhages near the surface of the cortex, they are a very good predictor of a future amyloid angiopathy natural history, including the future occurrence of the intracerebral hemorrhages. And then we see this literature which says, if we look at the pattern of the microbleed, that also helps to predict. So those tiny little microbleeds in the brain parenchyma. So both the surface bleeds, which are chronic, as well as the microbleeds in the parenchyma, they all are predictors of future ICH. And the risk is quite substantial. And if you compare the individuals who did not have these markers versus who have these markers, the risk could be doubled or tripled or quadrupled, depending upon the underlying entity as well as the dose of that entity. For example, the dose for microbleeds are the number of microbleeds. The more the number of microbleeds, the higher the risk of recurrence or the first ICH. And then finally, we are seeing this new phenotype, which is convexity subarachnoid hemorrhages, which were previously documented in patients with trauma, subsequently noticed to be a marker of cerebral venous sinus thrombosis, and now are being increasingly reported in patients with cerebral amyloid angiopathy. So again, we would not know if this subarachnoid hemorrhage is a part of CAA, or it is venous sinus thrombosis, or it is part of trauma. So of course, we need something to guide us to say how to distinguish amyloid angiopathy from these other entity which causes similar presentation. And again, it showed a very similar theme, which is the much higher risk of future hemorrhages. And this is another study which showed that if you compare all the ICH with or without CAA, there's clearly much higher risk of a recurrent ICH if there's an underlying amyloid angiopathy. So overall, the phenotypic spectrum is widening, and there are a lot of biomarkers which has been proposed and are now being used as a surrogate for a previous ICH, unlike before, where we needed to have only evidence of the bleed itself rather than these additional biomarker. And that this is also possible because now we have a better imaging, especially with the MRI. and specific sequences which are also evolving, and that we are detecting this entity more and more. So again, I'll describe about the diagnostic criteria and how it evolved, and what are the phenotypes which are being increasingly recognized. And again, intention here is not to discuss about the implications, especially from the management perspective. So it'll be mainly towards reaching the diagnosis. And of course, once we reach the diagnosis, then we can open up the chapter for discussing prognosis and how different conditions and medication interact with this condition, as well as the genotypes, how they interact with this and lead to different manifestations. So looking at the nomenclature or the definition, put it in a very simple terms, it is basically a deposition of the protein amyloid beta in the walls of the small arteries in the brain, so especially the leptomeningeal and the cortex. So it's basically a superficial involvement along the lobes, which is the common denominator in all forms of amyloid angiopathy, whether they are sporadic or inherited. So to diagnose a cerebral amyloid angiopathy, we need to demonstrate that this patient's either the biopsy specimen or hematoma specimen, or in other cases, the autopsy specimen does have amyloid beta. And this could be demonstrated by different stains. In the past, it was only amyloid stain which was used. And this is actually not a right terminology, because if we really look at all the words which constitute this entity, are not truly reflective of the true extent of this condition, because cerebral denotes mainly involvement of the brain, but we do know there are retinal involvement as well as spinal involvement in patients with amyloid angiopathy. So cerebral itself restricts the phenotype. Amyloid suggests there's underlying carbohydrate, which was thought to be the case because initially these deposits were stained by the carbohydrate stain and or a starch stain, that thereby the term amyloid. But now we do know that there is no underlying carbohydrate, but rather it's a protein deposition. Although there are some proteoglycans which are associated with, which probably led to staining with the carbohydrate dyes. And angiopathy, usually angio signifies more of an arterial problem. And again, we do know there are venular and vein involvement in this entity, therefore, again, restricting the phenotype. So all the term itself is not clearly depicting the extent of this condition. And we are now evolving more and more in terms of understanding the phenotype. But the core theme still remains the same, that the predominant manifestations are limited to the blood vessels which supply the leptomeninges and the small arteries which go into the cortex and the capillaries. And it occurs in two different forms, the sporadic form and the hereditary form. The sporadic form is the one which we will be discussing today in terms of the diagnostic criteria. But again, the theme remains quite similar, although the familiar forms have much earlier age at onset, more fulminant course, and much wider distribution. So again, retinal involvement is much more often seen with familiar forms than the sporadic forms. And again, I won't bore you with too much of pathophysiology here, but this is just one slide. And I'll just try to explain how the two entities coming from the same protein, they differ in terms of the pathophysiology. So if you see, the amyloid beta underlies both Alzheimer's dementia or Alzheimer's disease and also amyloid angiopathy. So it's the same protein, but there's a slight difference in terms of the forms. And again, there are different enzymes which work on this initial protein. We call it as amyloid precursor protein, which is a cell membrane protein. And this is broken down into smaller pieces. And one of the pieces has 40 amino acids and is called A beta 40. And another is called A beta 42. And again, this is due to the action of different enzymes which are activated under different circumstances, leading to these two different products from the same initial protein. And depending upon the subtype of the underlying peptide, the manifestation might differ. So if there's a lot of A beta 40, it goes into the vessel wall. And if there is more of A beta 42, it goes into the brain parenchyma itself, so among the cells. And A beta 42 then starts accumulating around the neurons and leading to what we call as the plaques. And this induces subsequent changes intracellularly, which leads to tangles or neurofibrillary tangles, which are nothing but phosphorylated tau. And so these changes in the parenchyma then subsequently leads to further neurodegeneration, and it goes for Alzheimer's dementia. While if there's a deposition into the vessel, there are three different themes. One is there could be a deposition in the wall, therefore restricting the movement of the nutrients and preventing the absorption of these metabolites, therefore leading to ischemic symptoms of the brain. The second is the wall itself might get compromised. Either it kind of distends or forms the aneurysm and ruptures, causing hemorrhages, or there is intimal changes, significant intimal changes causing luminal compromise and leading to ischemic symptoms. So there are ischemic spectrum and hemorrhagic spectrum, which I'll show in the next couple of slides. And finally, because there's a lot of disruption of the vessel wall, there could be a lot of inflammation which can occur either in the vessel wall itself, called cerebral amyloid angiopathy related inflammation. So one is the angiitis, and another is perivascular inflammation. Both are along the CARI spectrum, which is CAA related inflammation. And so inflammation, disruption in ischemia.
97 and 98.
Okay. Sorry, I thought it was for me. Okay. And so this leads to different manifestations. And again, looking at the cognitive decline, it is multifactorial, as depicted here. And so there could be a vascular phenomena leading to cognitive decline. So they get vascular dementia, or they could have coexisting Alzheimer's disease, causing this combination of CA Alzheimer's pathology. And third, there could be a neurodegeneration related with the CA itself. And now we understand there could be a neuroinflammation related to CA, which could lead to cognitive decline. And if we look at the evolution, so again, I kind of summarized previously that it has moved from the labs to the clinical domain, and now it has become more and more interesting from the imaging perspective. And there has been a big change from the early 20th century to the later part of the 20th century to the first 20 years of the 21st century. And if we recognize that there's a widening spectrum of the phenotypes. And so looking at diagnostic criteria themselves, as I alluded, before 1995, it was basically autopsy-based diagnosis. In 1995, the Boston criteria, the original Boston criteria was published, and this was a group from MGH. And subsequently, this criteria was modified as new biomarkers emerged, which again, I will show that how that got modified and what modification entailed. And more recently, we need to go into a different place. So Edinburgh criteria came into picture in 2018, which is a CT-based criteria compared to the previous two, which were MR-based and pathology-based criteria. And also now there's a widening spectrum with the inflammation, and therefore the two new criteria have come up for the amyloid angiopathy related inflammation. And again, looking at the spectrum, and again, we always want to look at one slide which kind of summarizes the different imaging as well as clinical spectrum. So if we look at the acute subacute presentation to chronic, and again from cognitive to encephalopathy or focal presentation, basically this is a summary. And what it describes is that the first is that changes in the vessel itself and the inflammation, which is the CARI spectrum. Then you have two different phenotypes. On the left, you have mainly the ischemic spectrum, where you have infarcts in the cortex, white matter changes, or acute infarcts in the cortex, or acute infarct in the white matter, and ischemic CA with vessel wall enhancement. While on the right side, you have this hemorrhagic spectrum where on the surface, you see chronic hemorrhage, which is superficial siderosis. You see chronic tiny little hemorrhage in the brain parenchyma called microhemorrhages. You have acute blood on the surface called sulcal SAH. You have acute blood in the brain parenchyma called lobar hematoma. And of course, there's the hemorrhagic CAA with vessel wall enhancement, which we think is probably another entity. And finally, there are dilated perivascular spaces and cerebral atrophy, which are probably interlinked because with the increasing deposition of the protein, there is a perivascular atrophy, which leads to dilated perivascular spaces. And this is also being recognized as a novel marker. And looking at the original Boston criteria, again, the theme is very simple. The theme is you want to capture the age, which should be older population. You want to capture that there is lobar presentation in the hemorrhage. And 3, you want to rule out any other causes which can have a similar presentation. So that's kind of a triad for diagnosing and development of this criteria. And if you see, the definite amyloid angiopathy is diagnosed when you have examination of the full brain. And while you can go to the probable with supporting criteria if you have some tissue diagnosis, either there was a hematoma sample or there was a biopsy done, which shows amyloid angiopathy. So it's still a tissue diagnosis and is being supported, but there's not a whole brain examination. So that becomes a probable, which is supporting pathological evidence. And then the third is if you don't have any pathological evidence, then this is called as probable amyloid angiopathy. Of course, that needs ruling out other causes, as noted in the bottom. And finally, possible is if only the age criteria and the hemorrhage criteria is met, while you're not able to rule out any other competing etiology, or it is not possible to rule out all the competing etiologies. So basically, we start with age and lobar hemorrhage and try to exclude other cause, and then we move to probable. Then we can add the tissue or add the whole brain, and increasing our certainty in terms of diagnosing amyloid angiopathy. So these 4 categories, they remain constant throughout all the criteria which subsequently evolved. And so if we look at the original Boston criteria, we have now evolved into modified or new Boston criteria. And between these 2 criteria, there were 2 biomarkers which were identified in those 15 years. One was these microbleeds, which are in the brain parenchyma, and second is this surface bleeds, which are superficial siderosis. So incorporating these 2 biomarkers into the Boston criteria, we have the modified Boston criteria. So essentially, the first 2 groups remains the same because they require tissue, and these criteria are based on imaging. So it's only the later 2 criteria got modified with recognition of these additional biomarkers. And what it needs is that each hemorrhage, each microhemorrhage, or each area of superficial siderosis represents one equivalent to one lobar presentation. So they kind of, instead of requiring recurrent or multiple, you can replace multiple lobar hemorrhages with multiple hemorrhage or multiple these biomarkers. So the multiplicity previously was only established by, and I should have emphasized that in the previous criteria too, that it has to be multiple, not a single hemorrhage. So the multiplicity can be established by these additional biomarker. Therefore, they kind of replace the need to have multiple hemorrhages in the brain. So that was the only change which happened in 2010. And of course, we always like to travel. So we moved from modified Boston to Edinburgh criteria. And my apologies, this should be 2018. And the incorporation was another biomarker, which was these finger-like projections. And although this was not previously established as a biomarker, but this was introduced in this criteria as a new biomarker. And what it tells us is that it's not a uniform homogeneous hematoma, rather it's a lobulated hematoma, which extends into each of these gyri. And this leads to these finger-like projections. And you can see here one finger, another finger, and a few other fingers. So that itself is thought to represent a marker of the amyloid angiopathy. Now, is it specific to amyloid, or is it just a reflection that the pathology is largely lobar in distribution, and when there's expansion of the hematoma, there's shearing of these other arteries, which is leading to this kind of a phenotype? It's unclear. And this has not been validated, and work is in progress to validate this criteria. And also, this criteria needs not only imaging, but it needs a genetic genotype, which is ApoE genotype. So ApoE is a lipoprotein, and there are different forms of these lipoproteins. Though ApoE4 has been implicated in cerebral amyloid angiopathy, or its hemorrhagic expression. So, and also it kind of included subarachnoid hemorrhage into this construct. So we now have hemorrhage, finger-like projection, and this ApoE phenotype. And of course, we need to exclude other etiologies or competing etiologies. And so this was a big change. And if this is validated, this will certainly help, because a lot of patients may not undergo MRI for several reasons, either because of the severe course and patients succumb very early, or because of the patient movement and many other factors. So I think if this criteria is validated, this will definitely help us to diagnose other patients which were previously remained cryptogenic in etiology. And further phenotypic expansion happened when we recognized that it's not only the hemorrhage and the ischemia which occurs in amyloid angiopathy, but there's a lot of inflammation which happens. And if you look at the white matter of this individual, you can see there's an expansile edema and a lot of T2 hyperintense lesion in the white matter. And that is similar to what we see in many of the leukoencephalitis syndromes. And this has also been interestingly noted, a similar picture in patients who were given a vaccine for Alzheimer's dementia. They developed this severe form of encephalitis, and many of the MRs were similar to this. So basically what it represents is that there's an inflammation which is happening in the vessel wall. And you can see here, there's an enormous number of these microhemorrhages, superficial siderosis, which is happening in this patient. And they also have this, because of the severe compromise in the blood-brain barrier and blood meningeal barrier. So you can see a lot of this enhancement either on the surface of the brain or in the brain itself. And it becomes quite challenging to diagnose, especially if it is frontally located, where it might mimic glioblastoma and many other conditions. So, and I think the key piece here is to do this sequence, which certainly helps to diagnose that this is amyloid angiopathy. And there are obviously many other differentials in the form of primary CNS angiitis. And if you see this is one form of CNS angiitis, and because it's limited to the CNS, it qualifies technically for primary CNS angiitis. But unlike the primary CNS angiitis, it's not typically a granulomatous condition, although there are some granulomas being reported. So, and the one distinction is there is no underlying beta amyloid, which is present in the vessel walls, which is unlike the CNS angiitis, where the beta amyloid has not a big role to play. And so now, again, similar to the hemorrhagic spectrum, how can we put things together, and what are the different combination of these imaging and clinical symptoms and signs which we can combine together to form a criteria. So these are the two criteria which were published in 2011 and 2016. And one in 2016 is a validation with slight modification. So it's both validation of the first criteria with slight modification. And again, the core theme remains the same. We will see that the age threshold has been lowered. Compared to 55, this has been lowered to 40 or above, and the clinical presentation has changed. The phenotype is more like an acute encephalopathy. So that means these patients have acute change in their consciousness, behavior. They might have seizure, they have significant headache. So that is the core theme, which actually is very similar to many encephalitis conditions, except that these patients do not have a fever. And if you do the imaging, they have extensive white matter changes, as we saw here, which are asymmetrical. Or the only difference between these two, or the major difference between these two, is that you don't need a significant asymmetry to occur in the possible, while in probable you need quite significant asymmetry between the two sites. So it again entails the age criteria, and then it has the imaging criteria, which has these conventional markers, the hemorrhagic markers, and additional marker for the inflammation, which is in the form of this white matter changes with enhancement, and the clinical presentation, which is not a very smoldering presentation of a CA with the dementia or hyperacute presentation with the hemorrhage, but rather in between, it falls in between, where they have a subacute onset of these global change. So the basic theme still remains the same with additional those components. And this is another phenotype, because we focus too much on the supratentorial structure. And there has been now increasing interest in looking at the cerebellar phenotype. And this is one of the studies where I was involved in, where we looked at the distribution of the cerebellar microhemorrhages in a patient who had supratentorial hemorrhage. And very interestingly, a very similar theme emerged as what we understand in the supratentorial or lobar distribution, that there is a distinction between the superficial bleeds and the deep bleeds and the mixed bleeds. Similarly, there's a distinction between the superficial bleeds and the deeper or the peridentate bleeds in the cerebellum as well. And again, it's unclear how much this is the primary manifestation, or this is merely an associated findings. So in the study which we looked at 134 patients, we did find that if you include cerebellum in the diagnostic criteria, it might lead to some reclassification from possible to probable, and some from probable to non-CA diagnosis. So this does have some interesting implications. So again, we would wait for a further validation and its incorporation into the regular criteria. And so again, we now understand that the phenotype is further expanding, and we did allude to, we did talk about the subarachnoid hemorrhages, and also these tiny little infarcts on the surface of the brain, which is cortical or subcortical. So therefore, the phenotype has become quite extensive. But again, if you look at my the previous slide, you can basically break it down into four main themes. One is the ischemic theme, the hemorrhagic theme, the degeneration theme, and the inflammation theme. And everything is kind of around those four themes. And the predominant theme has one core criteria, but does have supporting criteria from the additional themes. And if you look at these criteria which has been proposed, have they been validated, and how good, how sensitive and specific they are? Well, it depends on how the amyloid angiopathy has been defined. Is it a minimum criteria where you are just looking for any presence of any amyloid, beta amyloid, or presence of at least few cells showing? So it depends on the severity, and I will show you. This is one way we can, and I'll come back to this. This is one way we look at the pathology. This is based on purely amyloid stain. So we look at the amyloid stain, and based on how many vessels are showing, that is the extent of amyloid deposition, you can say it mild, moderate, severe. The other is the changes in the vessel itself. So that means there is the amyloid protein deposition, plus there are vascular changes, which you can see in the form of there are dystrophic changes, or there's damage to the smooth muscle cells, or there could be a splitting of the medial layer of the vessel. So depending upon whether you're just looking at the amyloid staining, or you're looking at the amyloid staining with pathological changes like additional vascular changes, this might significantly vary. And so this then determines what the sensitivity and the specificity will look like under different settings. And if you're looking at some of the studies which were done to validate these criteria, the specificity varies anywhere between 87 to 100%. So it's a fairly specific criteria. And again, it'll depend on what level of certainty you're looking at, because for possible there is much higher sensitivity but less specificity, while if you're looking for the probable and definite, there is a very high specificity and the sensitivity drops. So it's kind of a sometimes a balancing act where you want to not overcall, but at the same time don't want to miss this diagnosis given its potential implications. And this has also been looked into the familial types and has been validated. And looking at that second theme, which is the inflammation theme, this has also been validated and has been found to be fairly sensitive and specific, depending upon what level of certainty you need. And of course, when you are going for more certain, you increase the specificity at the cost of sensitivity. And if I have to put a summary here in terms of the core phenotype, which has been fully validated, is the intracerebral hemorrhage, the microbleeds, the surface bleeds, which could be acute, which is subarachnoid hemorrhage, sulcal subarachnoid hemorrhage, and superficial siderosis. And all of these, they increase the risk of future lobar hemorrhage. So even if you identify a non-ICH biomarker, it does predict the risk of first hemorrhage. And also, if you find after first hemorrhage, it predicts the risk of subsequent hemorrhages. So these biomarkers are very useful in stratifying the risk in these patients. And so in summary, amyloid angiopathy is prevalent among elderly. It has range of clinical and imaging presentation, which we are starting to understand. A lot of these imaging and clinical phenotype is now being incorporated into the diagnostic criteria, and becoming familiar with the diagnostic criteria will help us improve the diagnosis in these patients and prevent either unnecessary investigation to further look for some atypical etiology, and also reduce the therapeutic adventures which might happen over the course. For example, I discussed about the transient symptom being given antithrombotics, or a patient with CAA given anticoagulants, especially in the setting of AFib. And again, that is a completely different topic where we could discuss the management and what are the challenges in the management of these patients. But again, the idea was to kind of kindle some interest in this entity, and also recognizing that this is going to be a major condition which we will encounter both in the stroke world as well as in elderly population in general, both in the setting of cognition impairment and without. And I think cardiologists might also find it very interesting, because they might have to consider this entity when prescribing anticoagulants. And the risk, it does portray the risk of first ICH and the recurrent ICH, and the recurrence increases with the antithrombotics on board. And we still need to find the best criteria. And on the side note, we did our first EVT and we celebrated our 1 year. And so this was in 2020 February, we started the endovascular thrombectomy. And this was our first case. And we are very delighted that the program is expanding. And we are still limited our service, but hopefully this year we'll probably go 24/7. Thank you.
Thanks very much, Dr. Singh, and thanks for the little blurb on EVT at the end and showing our team here at Health Sciences North. We have about 10 minutes for some discussion and some questions. I'll read first from the chat. the questions that we received. And then if people want to unmute and ask their question or make a comment, that would be great as well. So the first question comment is, can Dr. Singh discuss the dilemma of antiplatelets and DOACs with AFib if they have a bleed and atrial fib?
Right. So I knew this was coming. I think this is a very interesting discussion, and I probably would love to bring up a lot of the literature which is coming up and discuss, and maybe we could have another session on this. But to briefly summarize, patients with amyloid angiopathy are at risk in general for the first ICH. And the risk of subsequent ICH is much higher. So of course, this needs to be considered when prescribing anticoagulants. Even in general, if it is a non-CA related hemorrhage, this consideration needs to come in while prescribing antiplatelet or anticoagulants. But it is the underlying etiology which determines. And if you really look at the intracerebral hemorrhages and different underlying etiology, one of the very important etiologies is amyloid angiopathy, which has a much higher risk of recurrence, unlike the hypertensive hemorrhage, which has a much lower risk of recurrence, especially if the blood pressure is controlled. So in the setting of, if you are not clear what is causing the ICH, it becomes a very, very difficult decision. Because you need to further stratify the risk based on what the underlying etiology is, because that'll give you a sense as to what is the likely risk of recurrent ICH. And for example, in patients who have hypertensive hemorrhage and the bleeding was mild, resolved completely, blood pressure is well controlled, and there are no other markers like not multiple microbleeds, I'm probably comfortable putting them back on anticoagulants. But again, people might debate this, and there's now emerging literature on this. There are a lot of trials which are being done, and one is Hamilton Run trial, which is looking into the first part of that trial called NASPAF trial that look at the safety and initial. Looked into the possibility of going with a bigger trial, and now I believe that's called ENACT trial is looking into prescribing edoxaban in the setting of previous ICH, and of course that results would be very, very informative. And there are many other trials which are concurrently occurring in rest of the world, which are looking into exactly the same question, but we don't have a robust data. There's a lot of observational data which is available, which is informing us a lot as to how to prescribe. But I would leave it for maybe further discussion. And again, comments are welcome. So honestly, I don't have a right answer here, but if you find this amyloid angiopathy, the risk of recurrence is very high, we should start looking for non-anticoagulant option like appendage closure, left atrial appendage closure. That's what I typically consider if I think the risk is much higher. There was a patient which I happened to manage, had recurrent DVT. We ended up putting IVC filter, and recently there was a patient who had multiple polyvascular disease and was on anticoagulation for graft protection, and we ended up stopping in that patient because that was too far out. So again, we might have to individualize, and it is important to look at the etiology, which informs the risk of recurrence, which then needs to be taken into account when considering the potential benefits with the antiplatelet or anticoagulant.
Thanks, Dr. Singh. That was my question from Timmins, but yeah, the question we get on stroke is when do you reinitiate the anticoagulation? Is it the size of the hemorrhage that matters? These are tough questions to answer, and it sounds like we need more data and maybe a whole new presentation on it.
Yes.
Thank you. We did have a comment from a physician in Hamilton that we can enroll the patient in the ENRICH AF trial at Hamilton General Hospital, which is trying to answer this question.
Yes.
Patients with CAA are being included.
Yes. So thank you for correcting. It is Enrich AF, which is investigating edoxaban. And it is Dr. Ashkan who's running this trial from Hamilton.
Excellent. Any other comments or questions? Would anyone like to unmute and ask something? Quick question from the beginning. You were talking about patients having transient symptoms, and I wondered if they are being seen in the secondary prevention clinics and diagnosed there with follow-up imaging, or is it happening right in the eMERGE department?
Right. So I think it is important, and this is one of the reasons that we end up doing MRIs in some of the patient where the symptom seems a bit atypical. And so to answer this question, yes, some of the patients are being diagnosed in the emergency department, especially if they have any of the conventional marker where there's a surface bleed or a small bleed. But a lot of patients coming to the stroke prevention clinic are being diagnosed because we have now incorporated the blood sensitive, the GRE sequence into the protocol. So we are picking up more amyloid angiopathies. And also we do look at some of the clinical aspects of the TFNEs, which happens in amyloid angiopathy, because TFNEs usually has a mixed picture where it comes with a combination of positive and negative symptoms. That's number one. And number two, they have a very interesting spreading tendency. So that means it's similar to what we call a spreading cortical depression, where the symptoms start in one area and kind of spreads, mimicking a migrainous presentation. So the older patient having a migrainous-like aura should be considered for imaging, unless you don't have any positive symptom and it's clearly negative symptom and you don't have a good suspicion. But otherwise, you should probably try to get imaging first before putting these patients on anticoagulants. But it may not be possible in many of these patients. So still we are pretty early in terms of understanding, as if you don't have a previous hemorrhage and patient comes with this symptom which looks like TFNE, well, how should you really manage? And again, it's a matter of personal preference at this point till more data emerges.
Very good, thanks. We have another question in the chat. I wonder if the dementia and memory clinics may be seeing more of these patients than our TIA clinics.
Sorry, I missed the last part.
Yeah, so I was just wondering if the dementia and memory clinics that are around the province may be seeing more of these patients than our TIA clinics do.
Right. Well, initially, unfortunately, it's clinically, it's very, very difficult. And if you see most of the referrals, they come to the stroke prevention clinic and it's then it is recognized. Now, of course, if the eMERGE is able to recognize that this is TFNE rather than TIA, absolutely these patients can go there. But a lot of these patients also have a lot of concurrent vascular issues, and eventually will end up in stroke prevention clinic either due to anticoagulation question or they are on antithrombotics, because this condition is mainly in the older population and who do have a lot of comorbidities. So a lot of these patients are already on antithrombotics. So even if they end up going to cognition or the memory clinic, I think we will still need the stroke prevention aspect to it to kind of balance the risk and discuss, what kind of antithrombotic it should be on and what the long-term outcome is. Of course, it would be fascinating to have a team which has both a cognitive neurologist or a geriatrician or somebody interested in cognition in the stroke prevention clinic, or vice versa, having a stroke neurologist or somebody interested in stroke management in the memory clinic. So I think we probably need a more of a multidisciplinary approach, which is kind of emerging in many centers, but as of now, we are still kind of quite segregated in terms of the care we provide. And it's hard to tell whether it is TFNE or TIA clinically. So it's mainly the imaging. So they're still appended in the clinic and get investigated, and then we label that this is likely a TFNE.
Great, great. I think that's all the time we have today. So thank you, Dr. Singh, for an interesting topic and conversation. And I can tell that you're passionate about this area. We look like we might have another topic to speak to in the future, so we'll keep that in mind. I'd like to thank everyone for joining us today and remind you to complete the evaluation. If you're completing a paper form, please send it into the contact listed at the bottom of the form. Our next provincial stroke rounds will be hosted by Toronto West Stroke Network and will be held on Wednesday, May 5th. The topic is stroke in the young adult, patient-reported outcomes and psychosocial needs, presented by Dr. Alexandra Pikula. We'll see you then. Thanks, everyone, and stay well.
Thank you, everyone.